My name is Leandra Weiss. I'm the nurse manager of the Women's Clinic, and I am thrilled and honored to introduce our speaker, Connor Wesley. Connor has been an advocate in healthcare for many years, I think starting off as an EMT and working as a social worker at youth care for homeless teens, and also has been a camp nurse for special needs, and currently he's working as a oncology nurse at Swedish, and so we're really excited to hear his presentation.
Thanks. Yeah. All right, welcome. I'm used to doing this to nursing students, so I'll try and gear it a little differently. But one of the things I like to start off today with is to create a safe space where we can all ask questions and participate in a way so that what's said in here stays in here, so that we can feel safe to ask the things that you might feel like, I don't know how to word this correctly, so it might be offensive, and to know that nobody's going to be judging you here in this room. I also like to challenge providers to use this talk as a way to start thinking about their own prejudices that they may have, because one of the things we do as providers is to show up every day knowing that somewhere deep and down inside we have prejudices, and our job is to put them aside and treat our patients with absolute and utmost respect. So I challenge you to start processing through what those might be for you. So today's agenda, we're going to learn the language, look at how we gender, identify consequences to being gender nonconforming, identify obstacles to accessing health care, and then learn how to be advocates. So we have to start with definitions and be on the same page. So sex, the state of being male or female. Gender, the behavioral, cultural, or psychological traits typically associated with one's sex. These are not the same thing, even though we use them interchangeably. An easy way to think about it is sex is what's between your legs and gender is between your ears. Intersex, a person whose biological sex is ambiguous, as in a different combination other than XX or XY. Gender identity, a person's inner sense of being male or female. Gender expression is the external manifestation of a person's masculinity or femininity. These, again, are not the same, but they are very similar. And sexual orientation, an individual's enduring physical, romantic, or emotional attraction to another person. So the only reason I put this definition on here is because oftentimes people mix gender identity and expression with sexual orientation. And I want to make it very clear that they are two very separate things. Transgender people are not necessarily gay, just like straight people are not, or, cisgendered, which I'll give you the definition of in a little bit, they're not necessarily heterosexual. So transgender, a person who identifies with or expresses a gender identity that differs from the one which corresponds to the person's sex at birth. I like to think of this as, I'm kind of a science nerd, so I took organic chemistry because I thought it would be fun. And so I think of carbon-carbon double bonds, and you have hydrogens. So the hydrogens that form on the same side of the double bond are considered cis, and then opposite are trans. And so the way to think about it, cisgender is where your gender and your sex align and are congruent, and trans is where your gender and sex are opposite and non-congruent. So transsexual is a person who psychologically identifies with the opposite sex and may seek to live as a member of this sex, especially by undergoing surgery and hormone therapy to complete the necessary physical appearance. And then that transition is what we use to talk about the process of undergoing that change. And I will say that transsexual is definitely a word that's sort of phasing out. It's very clinical, and generally people don't like to be referred to things that sound very clinical. Transgender is sort of an overarching term that encompasses a lot of just gender variants. And so the idea is really stepping away from looking at gender as male and female in this binary and realizing that it is a spectrum where people fall in any sort of space, and that there's not just one or the other. So genderqueer. Genderqueer is a person who does not define themselves as either male or female, and chooses to live outside that gender binary. So they like to live in that spectrum. A cross-dresser, a person who dresses in clothes characteristic of the opposite sex. This is not necessary for sexual gratification. I think sometimes people think of the old phrase transvestite when they think of cross-dressers. Drag queen or king. So this is somebody who dresses in clothes characteristic of the opposite sex for entertainment. And then gender dysphoria. So this is that persistent conflict between one's gender identity and their natal sex. This is the emotional upheaval that people that are transgender feel. Pronouns. So the first time somebody asked me what my pronoun preference was, I couldn't quite harken back to 8th grade to remember what that meant, so that's why I always put this here. So, he, him, she, her. Z here is one option, but generally people choose to use they or them, which I understand can be difficult to use they or them as they are plural pronouns for a singular person. But I can guarantee you that if somebody asks you to use these pronouns, if you struggle through that process, they will be very grateful. So other phrases you might hear: F to M to F, trans woman and trans man. So sometimes these can be difficult to wrap your brain around. So for F to M, the F, female, they were born female, their sex is female, and they live as male. A trans woman is a woman who happens to be transgender. I am a trans man, I am a man who happens to be transgender. And then cisgender. So this is an identification for people whose sex and gender are congruent. The do not use list. Tranny, he, she, she-male, it, shim. You will oftentimes hear people in the trans community using the word tranny. But for most people in our community, it still holds a lot of pain. And it has been used for a very long time as a very hurtful word. So I highly recommend not using it. The not so great list, transvestite, we talked about that earlier. It's sort of an old antiquated term. A transgender or transgenders is just a grammatical thing. A transgender makes somebody an object of a sentence and not so much a person. We are not transgenders. We are people of the transgender community. Transgenderism. I only heard this word a couple of years ago when I first started giving this lecture, and I read a peer-reviewed journal article on transgenderism, and I couldn't find a definition for it, so I ended up just looking up ism, because I thought transgenderism, pessimism, racism, these are all things that I don't think are good. And so ism means a set of ideals and beliefs. And I thought to myself, who I am is not just a set of ideals and beliefs, but my community is not a set of ideals or beliefs, we're people. So again, it's just sort of a grammatical thing. And then bioman or biowoman are similar terms to cisgender, but what this implies is that, and bio is short for biological. What that implies is that trans men and women will never truly be men or women because they were not biologically born that way. So the next step is to look at how we gender. Secondary sex characteristics, clothing, haircut, the way we walk and carry ourselves, our interests, our career selections. There are many things that you could add to this list. And that's, we make snap judgments every time we look at somebody. And we gender them. We figure out, do we use he, him, she, her just by looking at each other? And we wear clothing to express our gender because we want people to make we want people to gender us the way that we want the world to see us. So not only are they present in us, but we choose to present them in a specific way. And we learn how to do this very early on. We do it unconsciously. And we do it to babies. You see the beautiful bald baby with the giant flowery bow stuck on their head, because to those parents it is so important for them, for the world to know that my baby is a girl. We use pink and blue, and people want to know, oh, is your nursery going to be pink or blue? So it's something very important in our society. And so if we use the incorrect pronouns, people become very uncomfortable. And it, for some trans people, can create a very unsafe situation. because by breaking these gender norms, there are pretty severe consequences. The consequences are definitely more severe for men than they are for women. In our culture, it's okay to be a tomboy, at least until you hit high school. And then the pressure starts to be there to conform a little stronger. But for men, that it's very unsafe, and they're considered weak, and we associate them with women, which I don't think is necessarily a bad thing, but it's how we, as a society, try and break people down. So on here are some suicide statistics. So 41% of trans people attempt suicide in their lifetime, and these rates increase as you add every further incident of harm. And the highest statistics I saw said that 78% had tried to commit suicide. So you add rejection from family, discrimination, inability to find employment, health care, even being refused health care from a physician. And you compare that to our national average of 4.6, and it's a little scary. So that leads me to, so I'm not actually going to click on these because that'll take more time. And so these are some articles. The first one is an article about a 18-year-old individual whose name was Sasha, who identified as agender. So in that gender, queer, non-gender conforming category, and is male-bodied and was wearing a skirt on a bus, and a 16-year-old boy set this individual on fire. Because that 16-year-old boy saw that gender non-conforming individual and said, they are not human, and therefore I can set them on fire. And so, these are, the last one on here is talking about the increasing rates of homicide towards the trans community. And even though people like Caitlyn Jenner are coming out, our community is being murdered on a more increasing basis every year. And we as a community, every November 20th is the Transgender Day of Remembrance. So as a community, we come together every year to mourn and celebrate the people that were murdered because of their gender nonconforming status. Which is beautiful, but also sad that we as a community have to have that day to support each other. So I've also added Maslow's hierarchy of needs, which is something we talk about in nursing a great deal. So if you look at the very bottom, breathing, food, water, sex, sleep, homeostasis, excretion. The ability to use a public bathroom, is terrifying for most trans people. Because that's where being gender nonconforming is the scariest, because they're very gendered spaces. And I can tell you that women are very protective of their gendered spaces. I had security called on me several times before I transitioned. And so, for me personally, it became I became borderline agoraphobic. I didn't want to leave my house because I was afraid, what happens if I need to go to the bathroom when I'm out? Where am I going to find a safe place to be able to do that? Our community has I didn't put the statistics on here, but we have a very high population of unemployed and people that receive a significantly lower income compared to their peers. And so if you have poor income, you're not going to be able to get the food, you're not going to be able to find housing. And if you're applying for housing and you're gender non-conforming, you're going to run into all those other issues of people being uncomfortable because of your gender, which are going to cause you to further have difficulty finding these things. And so if we can't meet our physiological needs, our safety, as we go up the triangle, these become harder and harder to access. So the barriers to accessing healthcare are fear of being misgendered, fear of being further stigmatized, not receiving appropriate treatment, and actually fear of harm from your provider, whether that's physical or emotional. So this is Robert Eads. Robert Eads was the subject of a documentary called Southern Comfort. And he was diagnosed with ovarian cancer and could not find a doctor to treat him. And so he died from his cancer. The doctors, it says that he went to 24 different doctors and they feared that their other patients would leave their practice because they were treating this individual. So instead of risking the tarnish of their reputations, they chose not to treat him. And this is an article I found where a study they'd done in Virginia, where it said 43% of participants reported being out to their PCP. So that's less than half of people were willing to come out to their primary care physician about their gender identity. 15% of those people reported being uncomfortable discussing their transgender-specific healthcare needs. 20% stated they had to be the one to educate their primary care physician about transgender-related care. 25% were refused some sort of necessary health care related to their transition, so whether that's counseling, hormone therapy, or surgery. And 41% reported experiencing transgender-related discrimination in either healthcare, housing, or employment. So this is Virginia. It's definitely a different culture than ours, but I think it is applicable even to Seattle. And this is the reference. Another journal article, I can speak today, said, due to the social and institutional stigma against transgender people, their care is excluded from medical training. Therefore, providers approach medical encounters with transgender patients with ambivalence and uncertainty. Transgender people anticipate that providers will not know how to meet their needs, and in turn often choose not to go. So this was a review of journal articles on nurses' attitudes towards LGBT participants, and it essentially showed that 65% of these LGBT physicians heard derogatory comments about the LGBT community from their peers. 34% of them had witnessed discriminatory care of their LGBT patients. And then the study further goes to say that they think that attitudes towards transgender people are significantly less favorable than the LGB. So that's lesbian, gay, bisexual, and the T is transgender. And then 90% of transgender people surveyed by Lambda Legal believe there are not enough medical professionals who are properly trained to care for them, and 52% worried about being refused medical services when they needed them. And that's a pretty significant number and kind of a scary statistic. So, this is our safety pause, which I think we like to use in medical care. So possible times of tension and fear and concern for our patients that the patients are feeling when coming to the hospital. So, and it starts with calling to make an appointment. I'm always gendered female on the phone, so that can be difficult if I'm calling a new provider. And oftentimes people, when I say my name is Connor, think I'm saying Connie. So, it starts with making that phone call. And then you never know how the person on the other end is going to react. And then gendered waiting rooms. So for most of our providers, waiting rooms aren't gendered, but the women's clinic is definitely predominantly women. And then being called back. Oftentimes we call our patients back in a formal way. Mr. Wesley. My birth certificate still says female. So I've been called back with a beard by Miss Wesley. And oftentimes I get the tech, big eyes, deer in headlight look that's just like, what? The last time it happened, I had strep throat. I felt horrible. And the tech just looked terrified, stepped back into the room to look at her computer screen, looked at me, did it again, and I stood up and I said, no, you're right, let's go. And then proceeded to probably be much less polite than I should have been. And then she wondered why my blood pressure was high. And this, not only does it cause your patients emotional distress, but it creates an unsafe environment because now you've just outed them to an entire room of strangers that are going to have any wider range of responses. And then inpatient room assignments. So on our floor, often, we still have double rooms. And I know that many hospitals are trying to phase that out, but they still exist. So wanting to make sure that we provide our patients with a safe place, whether it's their own room or putting them in a gendered room in a space that they feel comfortable. And then for transgender people, getting to a point where they have to disclose either their natal sex or their gender identity. The last time I had to do that with a provider was when I was in nursing school, and the health insurance at school was horrible, so I couldn't see my regular provider because I couldn't afford it. And so $5 to go to the health center for a visit was something I couldn't turn down. So I'd initially gone for a cold or something. So, I'm not going to disclose to you that I'm transgender because you need to look at my throat. But when I chose to start seeing that provider on a regular basis, it meant that I needed somebody to write a prescription for me for testosterone, which means I had to disclose it. And I've been doing this for a long time, and even for me, it is still that moment of terror of how is this going to be received? Am I going to be able to get the health care that I need? And how much education am I going to be the one that has to do it? And then we go to physical exams, especially with little rapport. Sometimes we get our patients in, we haven't had time to build that rapport, and we're like, all right, let's hop to it. I need to, even lifting up a shirt to listen to their lungs. Many trans men wear binders to bind their breasts so that you can't tell that they're there. And so lifting up their shirt means they're going to be exposed in a way that may be very uncomfortable for them. And they may not have the emotional strength to be able to say, hey, wait a minute, I'm uncomfortable. And then referrals to outside providers. Again, I've been doing this a long time. I need my tonsils out. They're huge. They touch in the middle. Probably obstructing my airway a little bit. But I haven't gone to get that checked out because of that fear of finding a provider that's going to be comfortable treating me. If I need to have surgery, making sure that everybody I see is a safe place for me is terrifying. So our tools are pretty simple. Ask about preferred pronouns and name. I learned from the last lecture I did that Epic actually does have an option if your facility asks for it where you can list preferred name and pronoun. So that is something that we need to start doing, is getting our hospitals to get interested in this so that we can have that option for our patients. And then use those preferred pronouns and names. It can be difficult. It can be difficult if you have a patient that their gender identity or expression on the outside looks completely male and they're asking you to use female pronouns. Practice it in the mirror if you have to, but use them. It's the best way to gain rapport and trust from your patients. And then reflect back the language that your patient uses to you. So I identify as queer, which is a word that is still not comfortable in the entire gay community. It's not something that everybody wants to use. So it is safe for you to reflect it back to me because that is a word I've chosen to identify as. But I do not recommend going out to your friends and being like, hey, how's the queer community doing? Because some people might have a very negative reaction. And this applies to everybody, not just people that are gender nonconforming. If you have to talk about a patient's genitals, ask them the words they like to use. It does not make us lesser providers if we don't use technical terms. If you and your patient have a conversation about what they want to call their junk, if they want to call it their junk, they're now clear about what you're talking about, and you're now clear about what they want you to say and what you're talking about. You're on the same page. But forcing them to hear the word vagina when it makes their gender dysphoria skyrocket is just going to hinder your ability to work with that patient. Use that. Treat your trans patients just the way you treat any other patient, with compassion, patient-centered care. So, we are people. Our anatomy is slightly different than most and not what you expect. But if they've got it, treat it. Informed consent with your patients is really all you need. If you have a man with a vagina who's unwilling to get a pap smear and you tell them all the things they need to know and they still refuse it, that's informed consent. But If they've got it, treat it. And if your patient discloses that they're trans, try a simple answer like, thank you. Thank you for telling me. And then move on. Generally, there's a lot of anxiety and fear and turmoil that they have just experienced in having to come out to you. So if you dwell on it, you make them dwell in that negative energy that they're feeling. Tell them thank you. You can ask them, is there anything I can do to support you and where you're at with that? Would you like to talk about that more? And follow their lead. This is not a time for you to let your curiosity get the best of you and ask further questions like, what do your genitals look like? You would be surprised at how many people that find out I'm trans say, oh, have you had the surgery? It's not really an appropriate question. I don't even want to talk about that with my family, let alone strangers or providers who are only asking me out of curiosity. And then don't be anxious. If you have questions, just ask. Be honest with your patients about what your knowledge is and where it's lacking. Don't try and make things up on the fly. Be honest with them, and be honest with them in saying, "Hey, I don't have that information, but I can find it and come back to you with it." And then take a deep breath, because you're going to be fine. We're not that scary. And then I have a huge list of resources, and I know that these links are very small, so I will try and get them to a place where you can access them. There's a lot of continuing education, online things that you can access, the Endocrine Society guidelines, University of California, San Francisco Center for Excellence in Transgender Health. Ingersoll Gender Center, which is here in Seattle, has a lot of things for providers. They've even got a provider-to-provider listserv so that you can communicate with other providers, ask for assistance if you need help with a particular case, or provide other people with things that you've learned. And then the last is one of my favorites. It's safetopee.org. It outlines all of the gender non-specific bathrooms. You can look it up per city, so it's kind of like Google Maps but for toilets, which is an excellent resource, and I wish it was available much earlier. Because it's, we laugh, but it is one of the biggest sources of fear and anxiety for the trans community. And now it's time for you to ask questions. And on a personal note, I can say that as a transgender individual, choosing to transition was actually one of the hardest things I ever did in life. It was terrifying. I came out when I was 18 and promptly went back in the closet. I was in college in North Carolina, which was not a safe place, and it's still not a safe place to be trans. And it was terrifying. So, and trying to find providers that I would feel safe with was a daunting task. And so I didn't start transitioning until I was 27. So that was 9 years later. And even then, I had, it was when the Harry Benjamin standards of care were still very prominent and was the predominant way of treating trans patients. So I had a lot of hoops to jump through. I had to go to counseling. I had to live as the sex you identified with before I could get on hormones. And the counseling I went to was actually even more traumatic. I felt like the counselor I was seeing was asking a lot of questions that were very personal, had a lot of trauma behind them, and in our 3 sessions were not something that she needed to know to really address my gender identity. But because it was a hoop I had to jump through, I felt like I had to answer those questions. And then she proceeded to write down in like a 14-page letter to my primary care physician all of the things we talked about. So then going into my primary care physician for the first time looking for hormones, I was like, great, you read that. Neat. So now you know all these things about me, and I feel even more vulnerable and terrified. But I was lucky it was right when Capitol Hill Medical had opened their doors, which is it's a practice of providers that are all GLBT identified. I guess they're all GLB identified, and predominantly treat the GLBT community. So I was really lucky that I was able to find them, but that is not the case for many cities, to be able to find providers that are that supportive. Yeah, so it's still a process of finding providers that are terrifying. So I'm really glad that you guys are here today. So does anybody have any questions? I feel like it's quite great. No?
I had a couple. One is, could you talk a little bit about the prevalence and the rates of folks who identify as trans, and across also, you mentioned North Carolina in specific, just sort of across different areas. Is there any?
I don't know if there's data out there. I think there's this year they just did a national trans survey, similar to like the census. So I don't know if that data's out yet. We are a small percentage of the population. And we are also small in that generally people that transition will then hide in community, in the greater community, and not live as an out trans person because it is safer that way. For instance, I've been working at Swedish for almost a year now, and I would say that predominantly most of my coworkers don't know that I'm trans because still there's that safety of how are they going to respond to me differently. So our community likes to hide because it's safer that way. So, we're a small community, but we're everywhere.
And then just a quick second
Yeah.
follow-up, was you mentioned also Epic at the beginning, and one of the problems that we have as providers is that many of our systems do not actually anticipate the fact that a man could need cervical cancer screening and a woman might want prostate cancer screening. And in fact, some of our downstream, I run the lab here, and our reference ranges for tests
are specific to
We don't have a female reference range for PSA, and it might fail and might not actually do the test.
Right.
So things like that. Are there efforts ahead out there to ask these computer systems?
Well,
vendors
so Epic does create it, and it does exist. I had a person in my lecture, the last one I gave, who said, "Oh yeah, the last place I worked had things like preferred pronouns and names." So it does exist. The problem is we have to get our facilities to ask Epic to put it in the system, because everybody that runs Epic runs it differently because they've asked for their platform to be set up differently. So it exists and it's out there. I don't know so much about range references, if you'd have to somehow change the natal sex so that it'll run it correctly. So that is a much bigger issue. But yeah, when I get my testosterone results back, they're high. So yeah, I understand. And we even have, we look at hemoglobin and hematocrit differently based on sex. But really, adding hormone to my testosterone to my female body has increased my hemoglobin and hematocrit. So hormones do a lot of different things, and it's not just natal sex that's going to be determinant of what those results are going to be.
Since you've been working at Swedish, I was going to ask you a question about just best practices. If you've walked through Harborview or had any medical experiences here, are there things that Harborview could do better, not only as an institution but as a physical plant? Or have you seen things in Swedish since you work there that say, "Wow, this is forward thinking and should be emulated"?
I have not had experiences as patients at Harborview. I've done some clinicals here, and then as an EMT, I've brought a lot of patients here. But I highly recommend, especially for your clinics, to ask somebody to come in and do a safe place training and have safe place signs at your desk. There's also these great things that just came out, and I will find out the information, how to get them. They're called the Q card, and it's a tri-folded card, just the same size as like a business card, where a person can write down information like, these are my preferred pronouns, this is my preferred name, these are some things that you need to know about me, and then the very last slip is a thing of definitions that you can leave with your provider if you need to be the one to educate them. And so they're a card that the patient can bring and then hand to you. Instead of having to verbally out themselves, they can pass that note. but safe place training is great. Having overt signs of support. Safe place is something that the GLBTQ community knows about because it's the idea is that the providers are people, really it can be any space, have been trained on what it means to be an ally to our community. And so it's a little card that you can put up so that people know that whoever's in that space has actually gone through a training to be an ally, which is very similar to this. So that it's going to be a safe place. But it is hard in big institutions to create overt kind of gestures of support.
I mean, would you recommend us changing our name from Women's Clinic?
I don't know if Vagina Clinic would have this.
I'm just saying, I don't know.
I mean, I think trans men understand that they still need to access things that are considered women's health related. But I do recommend, especially if we can't get it changed in Epic, most doctors' offices still have you fill out a sheet of paper when you get there, adding preferred pronoun and preferred name, and then giving like a small list of what that means. Because I have a feeling that the majority of the world is like me when they first go, wait, what's a pronoun? When you ask for a preference. So, she, he, him as a quick list, then they, and then having them write it out. It's something small that you can add in. And then, heterosexual, cisgendered people oftentimes have preferred name preferences as well. So it's not just something that you're putting on there to target the trans population, but something that is very supportive. And some people choose not to fill it out, and that's fine. And, you can ask them very candidly, oh, I see that you didn't put that down. And they'll either say, yeah, I didn't know what that meant, or, oh, I didn't have an answer for you, which can open up the doors to further supporting your patients.
One of the things I've noticed here at Harborview is that a lot of our whiteboards that we use to track patients designate pink and blue for their patients.
Right. And we do that too. So in that case, you'd want to use pink or blue based on how the person identifies, and or how they present. But yeah. And the good thing is that many of those whiteboards are not in spaces where random strangers can see them or interpret them as to what we're using. But I think using like a purple would be cool, but I don't know if that's really going to be an option. Because there are many people that choose to identify in that spectrum and not as male or female, and don't want to be placed in that box. So it does get a little more confusing and keeps you on your toes. Does anybody else have any questions? Yeah.
Do you have any other thoughts or considerations when working with a trans patient who is not English speaking or of the majority American culture?
Interpreters are great. And being very honest about the cultural difference that you're not aware of. I have not had a lot of experience with transgender people of different cultures. I know that in many cultures it's much scarier than ours to be trans, and there are many cultures where it's a very honored and wonderful thing. Making sure that you have an interpreter, even if their English is enough to get them through a basic exam, using an interpreter so that you can have a deeper, more meaningful conversation would be helpful. And letting them know, hey, I don't know what it's like in your culture. Can you tell me about that? So that you can make sure that you educate yourself as best possible. Or instead of having them be the one to educate you, outside of your time with them, making sure that you find some time to use the internet and figure that out. Anybody else? Yeah, Beth.
Yeah, do you have any examples where it's an honored thing?
In India, they're called the Haraja, I think is what. Thank you. Yeah, and in some Native American cultures, they're two-spirit. They're considered, they're considered lucky enough to know both genders. So in some cultures, it's an honor. And I don't know if those more traditional cultures, when they come here, start to phase them out and sort of westernize. But yeah.
So you say it's an honor? How is it honored?
Go for it.
To talk about the Gita, in India it's considered a third sex, so neither male nor female. So they're honored in that they're expected to bless the births of babies, specifically boys usually, but at the same time they're considered a lower caste system than many others. So they're usually homeless and impoverished and have more healthcare needs that are met, and they live in the slums. So they're considered, lucky because they've been touched by both genders. But at the same time, more violent than they're discussing.
So speaking of housing, sometimes again there's like a all women's shelter.
Yeah.
And so again, some issues have come up when a male or maybe a trans man would like to seek housing, but really again, if we're trying to protect again women who have been traumatized.
Yes, and women are incredibly protective of their space, and so that's tough. We want to create a all-inclusive environment for women. So what does that look like? Does that look like trans women being invited into that space? Does it look like trans men being invited to that space? And I don't have the answer for you. Because cis women are so protective, and it is as needed for trans women as it is for cis women, and trans men as well, because they become even more susceptible to becoming a victim of physical or emotional harm, especially when they're having difficulties with accessing housing. I used to work at the GLBTQ specific youth housing for youth care called ISIS House, which was 18 to 22-year-olds who were homeless because they'd been kicked out of their house for being GLBTQ identified. And statistics show that 42% of our homeless youth population identify as GLBTQ. So even as young people, they're starting off on a real rough foot, trying to just find housing, employment. Yeah, so, all homeless shelters are terrifying places to be. Oh, let's go. Does anybody else have any questions?
Let's get Connor being
Yeah.
Great.
My background is critical care,
Mhm.
and do you have any, I would just love to hear sort of your perspective on when there's situations where there's a lot of maybe conflict in the family and the patient is transgendered and perhaps like comatose or can't speak for themselves, and there are a lot of these pronouns and things you try to be respectful of the patient, but they can be very triggering.
Yes.
And there's critical information that needs to be disseminated and decisions made. I would just love to hear kind of your perspective on that and how we can be.
That's tough. And you see that even in the GLB population of, a patient who's not able to have their needs met, or be able to vocalize what their needs are or wants are. For me, it would come down to power struggles. Is the power struggle between me and the family of using the patient's preferred pronoun really important at this juncture? Is it going to, yes, I want to respect the patient's need or their identity as, we'll say, male. But if the family is constantly using female pronouns, is it going to be easier for me to work with them or more difficult by creating that battle? And if it's more difficult, what really matters is the patient's health care and not so much if the family's on board with their gender identity. I've seen a lot of things in charts that are awful. We don't have a universal way of communicating about our patients in our charting system, and all of that is available for them to see if they want it, which is terrifying. And that's another thing that, I think we as a healthcare community need to start thinking of is how are we going to start communicating about our patients in a medical document. If a patient discloses their identity, if I come to you and say, I'm a trans man, in my chart, if you use female pronouns, I'm going to know that you're not a safe provider to return to. So making sure that in charting systems that we're using our patients' preferred name and pronoun, so that if they were to ask for those records, they'd see that we were respecting them in all levels of their care. So maybe communicating with the family in one way, but charting in another. But doing the best you can to support that patient's wishes and desires, regardless of what the family is saying or doing.
Thank you.
Yeah.
Yeah, it just recently came up in our clinic where after we signed a patient up for e-care, they did see a lot of things that they didn't agree with, and so kind of bring out again the policy and how to get those things removed. So again, kind of a learning experience. So if anybody needs that, I have it. Just a couple housekeeping things. Any nurses, again, this can go in your transcript for CE as long as you signed in. Again, this is a huge topic, and I know that I would love to have ongoing discussions. So again, if you're interested, please let me know and email me. And if you would like access again to the PowerPoints, I will have.
Yeah, my email's here, and feel free to use it. I'm available for a resource. So, yeah.
Let's just give them a